Okay, everybody, thank you for joining us today for the first Global Health Program's Global Health Speaker Series event of the spring term. We are excited to have you here. The Global Health Speaker Series is a monthly lecture on topics relevant to the expansive field of global public health. We're excited today to host two people from the Centers for Disease Control, Drs. Heitzinger and Dr. Anne-Marie Desermou, who are going to talk about the recent cholera outbreak in Haiti. So we were very grateful for them for being with us, taking the time to share their expertise with us. We're also happy to partner with the Division of Environmental and Occupational Health Sciences. A couple of housekeeping things. Oh, first of all, my name is Allison Lofthouse, Assistant Dean for Global Health here at the University of Illinois Chicago School of Public Health. So we are going to have a question and answer session upon the conclusion of their talks. Please feel free to submit questions into the chat at any time throughout the lecture. I'm going to turn it over to Dr. Kristen Malecki, the Division Director for the Division of Environmental and Occupational Health Sciences, who's going to introduce our speakers today. So once again, thank you very much for joining us. I hope you enjoy the lecture.
Thank you, everyone. It's my pleasure to introduce to you Kristen Heitzinger, Dr. Kristen Heitzinger, who is an epidemiologist and global waterborne infectious disease expert here with the Global Water Sanitation and Hygiene team of the Division of Foodborne, Waterborne, and Environmental Diseases at the CDC. She has extensive experience in global disease surveillance and previously served as the epidemiology chief at the CDC's Mozambique office and as a consultant for the World Health Organization program. In her current role, she works closely with the National Ministries of Health and other partners to provide technical assistance for the conduct of cholera, typhoid fever, and other waterborne disease surveillance and outbreak response. And she has several ongoing international partnerships to support waterborne disease surveillance, capacity building, and serves as a member of the epidemiology working group of the Global Task Force for Cholera Control. So welcome. And then we have Dr. Desermou, who is the branch chief for global health security for the CDC Haiti. She's had this role since January 2023, and she joined the CDC in May 2019 as a public health specialist, focusing on immunization and surveillance. She was born and raised in Port-au-Prince. She's a medical doctor and ENT specialist, offering work experience and training in the field of public health since 2012 at the Ministry of Health. She is currently from her start in public health, she's held various supervisory positions, including overseeing and training surveillance staff in Haiti's 10 departments at the Ministry of Health. And she was the national coordinator for vaccine preventable disease surveillance. And we are really looking forward to hearing more from her today, as she has also worked closely with the Ministry of Health to support the response to various public health emergencies, such as COVID-19 pandemic and the cholera outbreak that we're going to hear about today. So thank you all for joining us, and we look forward to their talks.
Well, thank you very much for that kind introduction and for the opportunity to present. As you mentioned, Anne-Marie and I will be presenting on the resurgence of cholera in Haiti. And I think I'll turn it over to you, Anne-Marie, to get us started.
So my name is Anne-Marie Desermou, as they mentioned, and Kristen and I will present today the resurgence of cholera in Haiti. This is an outbreak that started in October 2022 and is still ongoing today. Next slide, please. So this is the outline we're going to follow. We will give you a brief background on Haiti. We will also give you a brief background on cholera in Haiti, because we were talking about resurgence. So that means that we've had previous outbreaks in the country. We'll go into the global context and talk about the cholera upsurge, the increasing number of cases around the world, ending cholera, and how global health security has helped control cholera in Haiti. And then we'll go into the cholera resurgence in 2022 and the response that was implemented for this outbreak. Next slide, please. So Haiti is a country that shares an island with the Dominican Republic. It has a population of over 11 million people. It is divided into 10 departments. The capital is Port-au-Prince and located in the West Department. So this is the red dot that you can see here on the map.
Dr. Dazer, will you have cut out a little bit?
Next slide, please. So Haiti is a country that has been plagued by natural disasters such as hurricanes and earthquake from 2010 when we had a major earthquake. We've had hurricanes throughout the years, Hurricane Matthew in 2016, Tropical Storm Grace in 2021. We were of course affected by the pandemic in 2020. And as well in 2021, we had a presidential assassination, and that resulted in severe political instability, civil unrest, and inflation with the stabilization of the local currency. So this is the situation in Haiti currently. Next slide, please. So cholera was the first historical occurrence of cholera in Haiti was in October 2010. So before that, we have never recorded cholera in the country, although there was cholera in the region before, but we had never seen cholera in Haiti. The disease was introduced in the country in October of 2010. This is about 9 months after the earthquake that same year that killed over 200 to 300,000 people and displaced over 1 million people. The identified strain for this outbreak was the Vibrio cholera serogroup 01, L-Tor biotype of the Ogawa serotype. We immediately implemented a cholera surveillance system that provided guidelines for reporting, investigation, and response to this outbreak. The strain identified in Haiti spread to other countries in the regions and caused outbreaks in the Dominican Republic, Cuba, and Mexico. Next slide, please. At the time, this outbreak was the worst in history. So we recorded over 800,000 cases and nearly 10,000 deaths between 2010 and 2019. A plan was developed to eliminate cholera from the island by 2022. And with improved surveillance, increased access to safe water, and timely cholera case investigation, the incidence of cholera significantly dropped from 34 cases per thousand population at the height of the outbreak in 2011. We dropped to 0.06 cases per thousand population by 2019. And between 2019 and 2022, no cholera cases were confirmed in Haiti. Next slide, please. So in February 2022, the country celebrated 3 years without confirmation of cholera cases. And this is in spite of surveillance, lab surveillance, active case finding, laboratory testing of watery diarrhea cases. No cholera cases were identified in that 3-year period from February 2019 to February 2022. So Haiti was said to be one of the first countries in the world to be declared cholera-free. But unfortunately, by the end of that same year, in October of 2022, we confirmed the resurgence of cholera in the country. So right now, I'm gonna let Kristen talk to you about the global situation and the resurgence of cholera in the country.
Thanks, Anne-Marie. Next slide, please. So now we're going to pivot to the global context, where I think it's important to note that the resurgence of cholera in Haiti came at a time when the number of cases was increasing globally, which it has been since 2022, with countries that had not been affected for decades reporting cholera outbreaks. In 2022, 44 countries reported cholera cases, which represented a 25% increase from the number that was reported in 2021. And this trend has continued through 2023 and into the new year. The recent outbreaks have also been more deadly, with case fatality ratios being the highest reported in over a decade. So this is a significant cause for concern on the global level. So given this global upsurge in cholera, the World Health Organization, or WHO, classified this event as a Class 3 public health emergency after assessing the global risk of the upsurge as very high. This resulted in the engagement of all 3 levels of WHO in responding and coordinating with global partners, including CDC, through the Global Outbreak Alert and Response Network, or GORN, to be able to respond. The global upsurge in cases has also taxed supplies to respond to outbreaks. And in October 2022, the International Coordinating Group, or ICG, which is the body that manages emergency supplies of vaccines, temporarily suspended the standard 2-dose vaccination regimen in cholera outbreak response campaigns. And they're now instead using a single-dose approach. The issue with this is that the 1-dose strategy, while it's been shown to be effective to respond to outbreaks, the duration of protection is uncertain, and the effectiveness of this approach has also been shown to be lower in children. Next slide, please. So to fight cholera at the global level, there is, however, an Ending Cholera strategy, which is described in Ending Cholera, a Global Roadmap to 2030, which is a document that was launched in 2017 by the Global Task Force on Cholera and Control that is shown here on the left-hand side. The Global Task Force on Cholera Control is a global coalition of partners that includes CDC, with the Secretariat being led by WHO, that aims to end cholera as a public health threat in up to 20 cholera-affected countries and reduce cholera-related deaths by 90% by 2030 through the implementation of a multi-sectoral strategy. What you see on the right-hand side of this slide is a visual diagram of how different cholera control pillars are supported by CDC, with the surveillance, case management, lab, vaccination, WASH, risk communication, and coordination pillars covered. Next slide, please. So now I'm going to spend a few minutes discussing CDC's cholera work in the context of our larger efforts to promote global health security, given that both at CDC headquarters in Atlanta and in the CDC country offices, staff supporting these efforts generally do so under the umbrella of supporting global health security, thanks to the funding of the US Congress for this purpose. Global health security is comprised of 3 functions that you can see in the diagram on the right, and these include prevention of avoidable outbreaks, early detection of public health threats, and rapid and effective response to outbreaks when they occur. For over a decade, CDC has provided support to the Haitian government to strengthen these public health functions and thus enhance global health security, or GHS. To do this, CDC invests in 4 target areas in Haiti, which include surveillance, laboratory, workforce development, and emergency preparedness and response, which I'll talk a little bit more about in the next few slides. Next slide, please. For surveillance, CDC's support has involved the establishment and strengthening of surveillance systems, notably the National Epidemiological Surveillance Network that monitors notifiable diseases nationally in Haiti. In the time that CDC has been collaborating with the Haitian Ministry of Health to strengthen their surveillance systems, the number of notifiable diseases has increased almost tenfold, from 5 to 47. Suspected cholera has been included in this list, and the case definition has been adapted with CDC guidance. CDC and the ministry have also worked together to develop standardized surveillance data collection tools, produce daily situation reports, and set alert thresholds for when the number of cases of a disease surpasses a historical baseline level, which triggers an investigation. The ministry also now produces facility-based aggregate data reports using an electronic platform, which can be used to inform activities at the health facility level. Regarding support for laboratory systems, CDC has expanded the existing laboratory networks provided training to build the public health laboratory workforce, and enhanced laboratory testing capacity through activities such as training, provision of supplies, and remote technical support. The fact that both the 2010 and the 2022 outbreaks were confirmed between 48 and 72 hours is truly a testament to the laboratory capacity that Haiti has. Next slide, please. In terms of workforce development, CDC supports the training of frontline staff to identify, track, and contain outbreaks, notably through the training provided via the National Field Epidemiology and Training Program, or FETP, that you may have heard of in other contexts. We've collaborated with the ministry to provide training at all levels, including the surveillance officers at the facility level to detect and report disease cases, epidemiologists at the department level for investigation, analysis, and response, and rapid response teams to investigate and respond to cases. Finally, for the emergency preparedness and response target area, CDC has provided the ministry with support to conduct data analysis, interpret analytic findings, and visualize data to inform decision-making for cholera and other diseases. Next slide, please. So with that global context, I'm now going to turn to the resurgence of the outbreak that Anne-Marie touched on earlier, and how the Ministry of Health responded with the support of CDC and other partners. And then we'll open it up to your questions. So on September 29th and 30th of 2022, Doctors Without Borders, or MSF, as the organization is abbreviated in French, alerted the Ministry of Health to 2 fatal cases of acute watery diarrhea in pediatric patients. These cases came from 2 highly populated neighborhoods in the metropolitan area of Port-au-Prince, and stool specimens from those patients were sent to the National Public Health Reference Laboratory. On October 1st, the government confirmed 2 cases of Vibrio cholerae 01 of the Ogawa serotype after 3 years without a confirmed case. The current outbreak has not been explosive in nature, leading to an exponential rise in cases, but it has been associated with some cross-border transmission and detection of cases both in the Dominican Republic and in Turks and Caicos. Next slide, please. So one of the key questions that was posed at the start of this outbreak was, where did it come from? And so the Haitian Ministry of Health collaborated both with the Massachusetts General Hospital and in parallel with CDC's Enterix Disease Laboratory based in Atlanta to conduct whole genome sequencing and sequence analysis of the 2022 cholera outbreak strain. And this revealed that both the 2010 and the 2022 outbreak strains were from the same serogroup, 01, and the same serotype, Ogawa. It also showed that the antimicrobial resistance patterns of the strains were similar, and the genetic analysis suggested that the 2022 strain was related to previously circulating Vibrio cholerae in Haiti, as compared to an external introduction of the bacteria. And that was found by both the Mass General Hospital and CDC in collaboration with the Ministry of Health. Next slide, please. So given that the 2022 strain was related to the previously circulating ones, another key question is, why did it reemerge after 3 years without detection? And 2 potential explanations that were deemed most likely by the Mass General and Ministry colleagues and described in their publication that includes the figure that's shown on the right-hand side, were 1, there may have been persistent circulation of the strain in Haiti because of subclinical infections, given that 90% of cholera infections are either asymptomatic or have mild symptoms, and that over time, waning population immunity due to lack of exposure and then lack of clean water and sanitation really provided conditions that were ripe for clinical disease to be detected. The second possible explanation that they provided is that it's possible that the Vibrio cholerae strain has persisted in environmental reservoirs. Next slide, please. So I think it's important to mention as well that the context was important in the resurgence of cholera in Haiti, and that there were a number of factors that created the conditions of humanitarian crisis that fostered this reemergence and also hampered the response. In October of 2022, some 4.7 million people, or roughly 48% of the Haitian population, were reported as acutely food insecure. And this could have meant that the population was more susceptible to cholera disease. There was additionally rising inflation, increasing the cost of living, and in September and October of 2022, heavily armed gangs blocked access to the country's main oil terminal and seaports, which very much hampered access to fuel for response-related transport, clean water, food, and medicine. Finally, over 150,000 people are in a situation of displacement in the metropolitan area of Port-au-Prince, and 75% of those have been able to successfully relocate to host communities, while the rest are in displacement sites. Next slide, please. So with that background, I'm going to fast forward to the recent history of the outbreak and describe a bit what was published in the most recent situation report from the Ministry of Health, which was published on January 8th, or reports data through January 8th. So through that date, they have reported roughly 77,000 suspected cases, of which about 4,600 of those have been confirmed, with nearly 900 facility-based deaths since the start of the outbreak about over 2 years ago. The case fatality ratio, as you can see in the graph on the right-hand side, has hovered around 1% for quite some months, which is indicative that cases are being managed appropriately when they seek care per the WHO recommendation for case fatality ratio. Next slide, please. In terms of the demographic characteristics of the outbreak, the burden of disease has been predominantly among young children, with children ages 1 to 4 years representing about 20% of suspected cases. You can also see through this graph that children 5 to 9 also represent 15% of the total. Again, just underscoring the point that children have been disproportionately affected by the outbreak. And then, as you can see from the graphic on the left-hand side from the most recent situational report, nearly half, or 53% of the cases have been male. Next slide, please. So just to put the current outbreak into a bit of historical context for Haiti, as you can see on the table on the left, and I know, I'm sorry, the numbers are a bit small, but you can see that the annual case numbers of the current outbreak have ranged from about 20 to 55,000 a year, which, although this is much higher than in recent years, it's also much lower than the hundreds of thousands that were detected from 2010 to 2012. In the figure on the right, from the most recent outbreak, you can see that there have been 2 main peaks in the number of cases, but that currently there is a decreasing trend in the number of cases. Next slide, please. So finally, I'm going to turn to the outbreak response measures. So specifically, what did the Haitian Ministry of Health do to respond in coordination with CDC and other partners? Well, when the outbreak happened, MSPP, which is the French acronym for the Ministry of Health, set up an incident management system, which is typical of public health emergency responses. This system was made up of 8 pillars, of which CDC supported 5, which are listed here. There was also a coordination and logistic pillar that I did not list. In addition to setting up their IMS, the government also developed a multi-sectoral response plan that was developed to guide implementation of pillar activities, scale up preparedness in departments that were not yet affected by the outbreak, and also to advocate for improved security conditions to facilitate the response. As is typical in cholera outbreaks, it's not one entity that usually does the entire response by themselves, but rather there are different partners that contribute to the response of each pillar. And so in terms of those that were involved in Haiti, primarily those have been WHO and the regional office, PAHO, CDC, Doctors Without Borders, Partners in Health, USAID, and a number of non-governmental organizations or NGOs. Next slide, please. Just to note briefly some of the specific contributions of CDC, we did deploy 3 subject matter experts to support surveillance lab and WASH pillars early on in the response in November of 2022, and maintained response activation through April 2023, which was deactivated due to a drop in the case fatality ratio. Next slide, please. In terms of specific pillar support, I'm just going to go through a few of the key ones for surveillance and lab. WHO and the ministry have a longstanding collaboration to strengthen epidemiological and lab surveillance in the departments, both through support for human resources and also training of staff. The WHO has also had a long history of providing support for sample transport to the National Public Health Reference Lab from areas that are not reachable via road due to the security situation, which they continued through the most recent outbreak. As I mentioned previously, samples were shipped from Haiti to CDC headquarters in November 2022 to support whole genome sequencing. WHO and CDC also provided some support for laboratory supply procurement. And then in terms of publication and public sharing of the work that was done, the ministry and CDC collaborated to publish a morbidity and mortality weekly report describing the resurgence of cholera, and also the brief article describing the WGS results that I noted earlier. Next slide, please. In terms of case management, CDC is typically not one of the main partners for support of this pillar, and that was also true in Haiti. WHO, MSF, GESCIO, and Partners in Health were some of the key partners who supported the ministry's work to provide patient care for cholera patients. However, CDC did provide support for development and sharing of case management guidance and training materials, revision of the national case management protocols, and then also some limited financial support for implementing partners to provide patient care. Next slide, please. In terms of vaccination, our Haiti country office colleagues and also headquarters colleagues provided support for the implementation of oral cholera vaccine campaigns in zones where cholera has been persistent in the country and also hotspots of transmission. To do that, they supported Haiti's request to the International Coordinating Group for vaccine provision, which resulted in the receipt of over 1 million doses. And those were used both for an initial campaign conducted in December of 2022 and into subsequent campaigns in May and June of last year. Next slide, please. In terms of WASH, our WASH colleagues provided technical guidance on water treatment, water quality monitoring, and other WASH response interventions to support both the Ministry of Health and the National Directorate of Potable Water and Sanitation, which is called DINEPA for its abbreviation in French, and other WASH partners. They also provided a limited amount of financial support to the ministry and to DINEPA for WASH response activities, and also engaged with WASH partners more generally to enhance response coordination, promote the availability of WASH data, and to discuss support for WASH commodities and WASH staff. Next slide, please. In terms of risk communications and community engagement, this is a pillar that we actively supported in the previous outbreak and therefore had a number of materials already developed. but nonetheless liaise with the Ministry of Health to provide them with technical guidance and to be able to have a strategic plan for risk communication and use science-based messaging. We also revised some of the previous materials to update and improve upon those, develop new ones, and then also assist with the dissemination by the Ministry of Health for use by community health workers and others. And then finally, CDC and the ministry also collaborated to rapidly develop public service announcements on cholera prevention and treatment that were broadcast both in French and in Creole beginning in December 2022. Next slide, please. And in terms of our ongoing response efforts, we continue to work closely with the ministry to support them for both surveillance and lab in order to detect and respond to new cases. We're also continuing to work with the ministry to support emergency preparedness and response, which includes implementation of capacity assessments and development of a capacity building plan. And WHO continues to be a key partner in providing support for departmental level surveillance and sample transport. So it is certainly an ongoing challenge, but eliminating cholera as a public health threat from Haiti has been done before, and we can do it again. So thank you very much for your attention. We're happy to take any questions. I see there's one question in the chat. Has the standard of care returned to administering the 2-dose vaccine regimen for cholera? Are you seeing any vaccine hesitancy? For the first part, the 1-dose policy is still ongoing. And for the vaccine hesitancy question, I think I'd like to turn it over to Anne-Marie to respond on that one, if that's all right, Anne-Marie.
Yes, thank you, Kristen. We were actually worried about vaccine hesitancy, but we have seen throughout the different campaigns that have been implemented that there has been very little vaccine hesitancy. Traditionally in Haiti, there's very little hesitancy for vaccines.
Great, Dr. Malecki, if you want to have the questions from the room, that would be great. Thank you.
Can you hear us?
Yep, we can hear you.
Okay, great. I'm gonna let Dr. Dorovich ask his question. I think,
Is it picking up sound from here?
can you hear Dr. Dorovich?
Yes.
Yeah, go ahead.
Oh, okay. Yeah, this is more a question for Dr. Anne-Marie, and it's just about operating in current conditions in Haiti. There's many stories in the news about, since the assassination of the president, how there's been a descent into lawlessness and the streets are controlled by gangs. How are public health officials and public health staff and public health systems and structures functioning amid that chaos, or is the chaos sort of exaggerated in some way by what we read here?
Okay. So I wouldn't say that is exaggerated. I'm not sure what is being reported in international media, but it is quite difficult. So we have had to think a little bit outside the box. But we have been able to implement public health interventions. For example, for the cholera vaccination, one of the things that the Ministry of Health did with the help of some of partners is that we used local partners to conduct the campaigns. For example, we have MSF, Doctors Without Borders, that work in some specific slums and they have access. So they are the ones that would direct the activities in that area, making sure that the staff is safe. And whenever it's unsafe, they let us know so that we can get out. We have had to, the cost of doing business also has increased because of that. because for supervisions to go to do investigations, sometimes, especially if the ministry at the central level wants to support the department, then we have to go by plane instead of just, hopping in a car and going there to do the investigations. But we are doing our best in spite of the current situation to address the current outbreak. And it shows you that there are always solutions available when you really need to do something and to implement public health interventions. So we have been able to respond. Maybe we could have done more and we could have done better, but I think we have been able to do a lot in terms of response for this outbreak, considering the current situation.
We have another question in the chat. They are curious of how people have managed to deal with the co-infections of cholera and COVID and what that means for the local community.
Well, to be honest, I don't think we've seen co-infections of cholera and COVID, especially since the symptoms are very different. And I have to say that the burden of disease for COVID in Haiti has been relatively low. For example, in 2023, there were no deaths registered from COVID-19 in the country. So we don't have a lot of COVID infections, at least not reported through our surveillance system. So we have not seen co-infections of cholera and COVID, and the health system has not really been overwhelmed by cases of COVID, especially.
Thank you so much. So this is such important work that you're doing in terms of global infectious disease production and control and really sort of challenging situations. And we have a lot of students interested in environmental justice, community health, also potentially global field work. So can you, both from your different perspectives, talk a little bit about your preparation as both a trainee and then where you've gotten today to be how you've gotten involved in this work and being on the front lines of working towards this, and maybe one or two most important skills you've learned along the way?
You want to start, Kristen?
Sure, yeah, I'm happy to. So I think one thing that was very key for me in terms of preparing me to do this type of work was some of the work that I did and experiences that I had when I was a graduate student. I went to Peru and did community-based studies on a number of topics, but including household drinking water quality. And I think that experience, both helped me in terms of having foreign language skills, which has been very key, in my career in general, and in my current position. I think also just the experience of developing your own data collection tools and then actually using them and having to engage directly with the community and the local public health authorities is just very valuable in terms of being able to do similar work in different contexts. So I think those are the two things that come to mind in terms of what prepared me for the future of my career.
For me, I can say that I started my career with the Ministry of Health, working in surveillance, mostly for vaccine preventable diseases. So like Kristen just mentioned, working to strengthen surveillance, develop tools, training, personnel. So all of this put together with, I'm also a graduate from the FATP training. So this also helped me to really hone in on the skills that I needed to do the work later on when I went to do my graduate studies and I came back to the country. It helped me to determine what I wanted to do, how I wanted to do, and also something that is very important is to determine how you work with governments, because working with governments is a skill in and of itself. Because as a partner, you have a way of approaching the government, of assisting the government in in supporting their priorities. So to me, having that prior experience in government and then later on formally getting that formal training as in public health helped me a lot into to develop my career and to continue to assist the country in addressing public health threats such as cholera.
Dr. Giles.
The two of you, this has been a great presentation. I just wanted to follow up on Dr. Malecki's question and asked about, are there opportunities for students to do electives or rotations at the CDC or within your group? And if so, how would they find out about those opportunities?
Yeah, that's a great question. I know that there is there's a few things. I think for graduate students, there might be less opportunities if they aren't based in Atlanta. But there are postgraduate school, be it master's or PhD training programs that are, fellowships of 1 to 2 years that you can take a look at. I think if you probably Google the fellowships, CDC fellowships, you should be able to find it. Otherwise, I can take a look myself and send the link to Dr. Malecki that should point you in the right direction. But those provide some of the public health training experiences like the one that Anne-Marie referenced.
Thanks.
We have another question in the chat asking if you could describe USAID's role.
Anne-Marie, would you mind taking that one? I'm happy to comment as well, but I think you
Sure.
might have a closer look at it than I do.
Sure. USAID, as a development partner, invests a lot of money into Haiti, and they support a lot of healthcare delivery in Haiti. So with this outbreak, one of the things that USAID really assisted the country with was with the procurement of commodities. So we were able to centralize the procurement of various commodities such as chlorine and other inputs for case management. So together with PAHO, they really supported the country in terms of the procurement of all those different commodities. And then just like CDC, they supported the country in various in different pillars. So traditionally, CDC works with surveillance and lab, and USAID would work more with communication, case management. They did a lot in WASH as well, and supported some of the vaccination activities through their implementing partners. And then we as a CDC, we had a whole of USG approach where we coordinated a lot of our support so that there was no overlap of this support that we were providing to the country. Over.
Thanks. Your comments raised one more question for me as an epidemiologist. I'm thinking about cholera as a legacy public health problem. Oftentimes it's the first type of outbreak as students we all learn about. Has there anything about technology or where we are in 2024 now that has changed sort of case definitions or how we tackle the problem, or new technology even from 5 or 10 years ago in this newer outbreak versus what you were dealing with when it was almost ideally eradicated from the country? Is there something different about this outbreak investigation than previous?
I would like to say no, just because the context of the country is different now than when it was in 2010. We're not dealing with this security situation that we're dealing with now, where where people are not able to move around as much. I mean, maybe we could say that communication technologies and the fact that people are able to communicate through WhatsApp or Zoom or things like that has helped in terms of training of personnel, in terms of meeting with the local staff, and for just capacity building and just in the planning process. Because a lot of those meetings that happen online were virtual meetings, so we didn't have to go physically to the site to have those meetings. We're not obligated to go to sites for training of epidemiologists or for case management and things like that. So I could say the technology in that sense helped a lot, especially in this context. But it's really mostly communication technology. In terms of everything else, I think it's mostly the same.
Is there anything you wish you had that you don't have?
The freedom to move freely, I guess. Because I think that's one of the reasons we were able to control the outbreak. In the beginning, we had those rapid response teams, and as soon as there was a suspect case, they could go on site, take care of the patient, take care of the contacts, provide prophylaxis, take everyone that needed to go to the health facility. They could take them to the health facility, and they could do a number of things to identify the source of the outbreak and to stop transmission. And this is much more difficult right now because they have to think about the current situation where they can and cannot go. Over.
Yeah, and unfortunately, globally, when we think about these issues, doing public health in crisis situations is something that I think we'll all continue to face for a long time. Related to the technology, have there been advancements in the genome sequencing tools that you're able to use, or are the traditional tools just as useful and practical?
I think that question probably be most thoroughly answered by our microbiology colleagues. But to my knowledge, the genomic sequencing tools that were used as part of the most recent outbreak are standard. So it isn't really something novel that was used. However, I would say that, because our knowledge of the sequences improves, constantly, that would be something that would be new, that adds additional insight to facilitate the analysis and interpretation of results.
Dr. Dorvich has another question.
Yeah, thanks again for the amazing talk and for doing the work you're doing in pretty hostile circumstances. Any cholera outbreak investigation would be challenging, but this is extra difficult for sure. The cholera responses usually involve wash interventions like point of use water chlorination or promoting the use of improved latrines. But ultimately, sewerage sanitation and centralized drinking treatment are obviously more lasting ways to improve public health through infrastructure. Is everything that's happening in cholera in Haiti now sort of the putting a Band-Aid on type of POU chlorination, or is there any movement at all towards wash infrastructure upgrades?
I would say yes. WASH is always at the center of the response for cholera. So there are the short-term interventions such as putting in hand washing stations at different points, and improving sanitation at the health facilities and at the community level. But there are some more longer lasting interventions for access to potable water that are being done. But the thing about WASH is that it's expensive. This is not something that most partners will invest in because it's an expensive intervention, and it takes time to put in place the infrastructure to provide potable water and to make sure that everyone has access to safe waste disposal. There have been improvements and there have been major improvements over the years, especially due to the first outbreak, but we still have a lot to do. So we are conscious that WASH is essential for the control of cholera. But like I said, this is something that is very expensive that few partners won't really want to invest in. But the plan that was developed initially for the elimination of cholera put an emphasis on WASH activities as well. So this is something that is still being discussed and that we are still working on. Over.
Thank you.
I have two more questions in the chat, and hopefully we'll be able to get to them before the hour. One is, can you comment on the community's trust level in healthcare workers and what could be done to increase the community level of trust?
I don't, how could I say this? The distrust is not necessarily in the community, in the health worker, specifically, but really mostly, distrust of the government. So in the beginning of this outbreak, people were not, the community was not sure if it was true. They were saying there was no outbreak because of the general situation. They were thinking that this was something to distract them from what was going on in country. But generally, I wouldn't say there was a distrust in the healthcare worker. It's just that traditionally, this is a country where people believe in their traditional medicine. So they will probably, when they present symptoms of cholera, they will probably start treating themselves and using traditional remedies instead of going to the health facility. And this is why we had seen a lot of deaths, especially in the beginning of the outbreak, because patients were arriving too late. And this is why the communication campaign was very important in the use of community health workers, because for this outbreak, we really relied on community health workers to go into the communities and educate them on not re-educate them, if I could say it like that, on the signs and symptoms, on what to do when they when they see those symptoms in their family members, just making sure that people get to the health facilities on time. So I think we have been able to address that distrust that we had in the beginning. We have been able to address that through the communication, through the proximity that we have created through our community health workers. I don't know if that answers your question.
Yes, thank you. And then last question I got was the US Peace Corps, what role could they have had if they have been allowed to travel to Haiti?
Kristen, you want to answer that? I'm not familiar with the role of the Peace Corps.
Mhm. Yeah, at least I haven't had experience with the Peace Corps in Haiti, but from my experience in other countries, I would assume that they would be part of the effort to educate the community, given that there are health education volunteers. So I would expect that they would have a role that would be similar to that of a community health activist or community health worker.
think just one question. This has been a fantastic talk. You've given us a lot to take in. I think everyone's grappling with, the issue of just the outbreak itself, but then the context, the security context that you're operating in, and the challenges that you're facing. I'm just wondering if you have any main takeaways from your responses to these cholera outbreaks that you've been able to apply in other aspects of your work.
Anne Marie, would you
I would say
like
one
to
of
take that first, or?
the
Go-
things that
sorry,
came
go
out
ahead.
of this. Yes, can you hear me?
Yep.
Sure, can you hear me?
Yes, we can.
Yes, so I think one of the things that really was great in this outbreak and how it was managed is the leadership role that the government, the Ministry of Health took, and how we really strive to coordinate the response. And this is important to apply to any outbreak or any public health event that occurs, because in the past we have had, um, especially when we have NGOs and other partners working, we have had people, just doing their own thing in their little corner and not really informing the other of what is going on. So I think that was that was very great. The level of coordination, the level of leadership that was shown throughout this outbreak, and that really helped control some of those hotspots fairly quickly. So I think this is something that make sure that any other outbreak that we encounter, the host government and between partners.
Okay, so unfortunately, thank you very much for that response. Unfortunately, you did cut out a little bit at the end. We are right at the end of time. I want to thank Dr. Heitzinger and Dr. Desermu for joining us today and for sharing their expertise with us. Please join us at the next Global Health Speaker Series. Stay tuned for announcements on that. Once again, thank you everybody for taking your time to be with us, and have a wonderful day. Thank you very much.
Thanks, everyone. Really appreciate the attention and the great questions.
Great.
Have a good day.